Professor Ludlam, just wanted to ask you next about any non-bleeding disorder patients you may have had who were infected through blood or blood products. Without...
Excuse me, did you want to discuss the... sorry to interrupt.
No.
The question I was posed about the report you wanted me to look at in relation to table 316.
If you're in a position to do so now, then absolutely.
I'm happy to do so, but I don't want to interrupt you.
No.
I'm happy to discuss it later, whichever you like.
Yeah, we can do it now. So the document was Hcdo 40132 _ 042. And then we had table 316 in the Penrose report. Shumik, could we put up side by side? It will just make it easier for others to follow. The relevant page of the Penrose report, which is PRSC 30. So no, it's not the second page of the document. PRSC 307002, page 107, I think. PRSC, the other one, Hcdo 40132 _ 042.
I can see the table. If it's possible to have the first page of the document that ends in 042.
Shumik, we've lost the table now. It's the table we want next to the document we've got on the left-hand side. Don't worry.
If it won't go, it doesn't matter. If I could have the table.
We may as well do it document at a time because it might be easier.
Okay.
Well, should we start then with the table, Professor?
Yes, I think that would be most helpful.
Okay, so Shumik, if we have PRSC 307002, page 107 again. So you should have the table now, Professor Ludlam.
Thank you. This, the sheet you showed me, I think relates to E7. The dates are the same. Okay. I've had some difficulty with the text below on the form, but I think my interpretation is that the sample on the 26th of June for this patient was originally a negative result and was actually a positive result. And that's why it's appeared here. I'm reasonably confident these results in 316 were carefully looked at, and I think this is a seroconverter, despite what it says on the form by saying it is not, that he did receive the indicated batch, and maybe this is the, if I can put it that way, the 18th patient.
Okay, and patient E7 was treated by, in the Penrose report, as forming part of the Edinburgh cohort, so...
Yeah, right.
Okay, thank you. Thank you for that clarification.
That's the best I can do at the moment.
So I just wanted to ask you, without going into the details of any individual's case,
yes.
the extent to which you had other patients, not bleeding disorder patients, who were infected with HIV through blood or blood products. The inquiry knows of one, and you have responded to, or you've seen details of the individual statement and responded to it, who was a patient with leukemia and AIDS from transfused products in 1983. Did you have any other patients, to your knowledge?
Yes, I did. Could I ask for the document to be taken down? The table 316 is still on my screen.
Yeah, we finish with that. Thank you, Shumik.
Yes, I had one other patient who became infected from a transfusion.
And do you recall what year that was?
When they became infected or when I first saw them?
The latter, but if you're able to provide both pieces of information, so much the better.
I think I probably saw them in 1986, around then. They were referred to me because they had, am I at liberty to?
Well, I think it might be wiser not to go into details about the individual.
I can say they were referred to me because they had evidence of immune deficiency, and they had been actually around quite a number of other physicians before they reached me, and they were sent to me as an unexplained case of immune deficiency. No one had thought could identify what the cause was, and as part of hematological practice, we saw patients with immune deficiency from time to time before the days of HIV, and so this patient was referred to me, and it became clear to me very quickly that this person has become infected from a blood transfusion.
And do you know the year in which the infection took place?
I would be guessing, but I think about 1983 or 4.
You've told us of your understanding that Scottish concentrates were safer than commercial concentrates. Would it be fair to say that in 1983 and 1984, you viewed AIDS as an US problem and therefore something affecting only commercial concentrates?
I would have seen it predominantly as a problem in the US. I would have seen that in countries where AIDS was occurring in the non-haemophilic population, the general population, there was a possibility the blood supply could become infected. But I suppose in 1983 and 1980, certainly the first part of 1984, it was very much seen as a problem emanating from the United States. The inquiry will be aware of the survey that Professor Bloom did around haemophilia centres in Europe. He was really a leader in exploring some of the implications of potential for spread of HIV or HTLV3 in those days by blood products, and as is well established, it didn't appear that there were cases of AIDS in, for example, Germany, that was a large user of American concentrates.
When you were, I'm sorry.
Yes, no, I'm finished. Thank you.
When you were considering the safety of the Scottish product, what, if any, consideration did you give to the extent of the IV drug problem in the area in which you were practicing?
I don't think that featured very highly. It certainly obviously wasn't known about that there was HIV in the Edinburgh drug users. That didn't come known until I think quite late in 1985, and was a bit of a shock. So it wasn't known at that time that there was infection, and I don't think there was, and not that I had heard of anyway, any evidence of clinical AIDS in the drug users. As far as I recall, I'm sorry, I've forgotten Roy Robertson's. As I think the inquiry is aware, also because he had tested his patients repeatedly for viral infections, there were samples in the virology deep freezes, and it was almost certain that those would be tested for seroconversion times. I'm sorry, I forget. I think it was fairly late. I think they were. Might have been 1984 that the virus was found to have got into the population, but I'm not certain.
I think it's fair to say that in Scotland there was a fairly close working relationship between the Scottish Haemophilia Centre directors and SNBTS. You've referred to it in your statement, and we've seen samples of some of the regular meetings that took place. For the benefit of the transcript, was that an agreement?
Yes.
And am I right in understanding that Dr. McClelland had, I think, an office on the same corridor as you, or certainly physically fairly close?
Yes.
Do you recall whether there were, in the first part of the 1980s, particularly perhaps in 1983, 1984, any discussions between SNBTS and Haemophilia Centre directors about the extent to which the donor population for the area had risk factors, or was regarded as safe?
I know that Dr. McClelland was very active in considering, if I can put it this way, the at-risk donors, and was very active in developing information to make available to donors to try and exclude those in the high-risk group. I don't recall any discussion or any suggestion that the high-risk groups were any evidence they were infected.
Did you know, again, 83, 84, did you know whether blood was being collected from prisons in Scotland?
No, I had no details of where the blood transfusion held its donor sessions.
So would it follow from your answer, you also didn't know whether or not blood was collected from military institutions or US military stations in Scotland?
That's correct. I didn't know.
Just wanted to come back to the question of hepatitis B, which you've already touched on your evidence by reference to the outbreak in 1969, 1970 in the dialysis unit. Do you know from your work in Edinburgh, whether in the first part of the 70s or your work there in the 80s, what, if any, steps were taken in Edinburgh to consider whether there were lessons to be learnt from that outbreak for the delivery of care by the Haemophilia Centre?
Well, I think it was don't know how much it was as a result of that outbreak, but maybe it was that hepatitis B in particular, but also non-A, non-B, could be spread to staff, as we were thinking, and also relatives.
But did that affect the approach that was taken to treatment decisions at all, to your knowledge?
I'm sorry, I can't think so at the moment.
We know from a paper that was published in 1983 that you co-authored, I'm not going to go into the details of it, that there continue to be hepatitis B infections, in particular amongst severe haemophiliacs, in the 1970s.
Yes, that's correct.
Once you arrived back in Edinburgh as director in 1980, to what extent was hepatitis B an issue? To what extent were there infections of patients with hepatitis B in the course of the 1980s?
It was pretty rare. I can think of one episode that occurred and that we were able to deal with very rapidly. It was, of course, at the time when the Hepatitis B vaccine was becoming available, and that was licensed in the early 1980s. It was prepared from hepatitis B positive individuals from the States, many of whom were gay men who were actually very good, regular blood donors and were happy and keen to donate their positive hepatitis B positive blood for the vaccine. These were obviously the individuals who were also at risk of HIV, and although the hepatitis vaccine was licensed and had undergone 3 viral inactivation steps in its manufacture, there was still some uncertainty about its safety when HTLV3 became a problem in New York. And for that reason, there was some reluctance to use it. I, in fact, was persuaded by a colleague who came from NIH to see me over dinner. I was discussing this with him, and he said he agreed that it was an anxiety, but he thought it was safe, and he'd recommended it for a member of his family. On that basis, I thought, okay, it probably is all right, and I was prepared to have it. If I was going to offer it to other people, I thought I'd better have it myself. So I had it. It's actually a very potent vaccine and has been perfectly safe, and we vaccinated those who were at risk.
In relation to the episode that you recall there being an episode of hepatitis B, can we look at one document just to see whether we're talking about the same one? LOTH 605_073, please, Shomek. So this is a letter the 10th of May, and if we just go down to the bottom of the page, 1984, to Dr. McClelland, from you, and I'm just picking it up in the last sentence. Our recent cases of hepatitis B infection in 2 Christmas disease patients is referred to by you there. Is that the outbreak or occurrence that you're referring to, or were there further ones?
That is the one I was referring to.
Did any of your patients go on to suffer serious illness, or, either in the short or long term, as a result of hepatitis B?
There were 2 patients who were chronic carriers of hepatitis B. One was in Edinburgh for a few years and then went to live elsewhere in the country. I don't know where the other individual lives at present. He may still be in Edinburgh or registered in Edinburgh. I obviously don't know.
I'm going to move on to a separate topic now, Professor Ludlam, which is to ask you about UK Hcdo in the 1980s, and in particular the role of the reference centre directors. So we can take the document down. Thank you, Shimmick. And you'll appreciate, Professor Ludlam, there aren't very many reference centre directors from the 1980s who I can ask these questions of. What was the purpose broadly in the 80s of the reference centre director meetings?
It was UK Hcdo was set up, as the inquiry will be aware, in 1969 as a group of interested physicians who looked after people with haemophilia. It was quite a large group of people, because in those days haemophilia was treated in very many local district general hospitals because they were close to where the patient, or closer to where the patients lived. And when they were needing hospital treatment with cryoprecipitate, then if they could go to their local hospital, then that was much more convenient. So there were a lot of hematologists, mostly hematologists, treating people with haemophilia. And then there were a small group of hematologists who had a particular interest in haemophilia. They tended to be, not exclusively, from the larger centres, and it was their full-time responsibility. Whereas in my case, I had large numbers of lymphoma and leukemia and patients to look after, and all sorts of patients to see around the hospital. The group of people like those from the Oxford Centre and London centres were full-time in looking after people with haemophilia. And they formed this reference centre group. And I think they were called reference centres because they were so designated, I think, by the DOH. And in fact, they were described, I think, as supra-regional centres, and they may have got financial support because of that. But if you like, they formed the steering group for UK Hcdo, this informal grouping of physicians that developed in the 1970s and went on to become a much bigger organisation and a more formally organisation particularly the 1990s.
So what was the objective of the reference centre director meetings?
The objective was to consider topics for improving haemophilia care in the UK.
I'm going to look with you in a few minutes with some of the reference centre director meetings from the critical years, late 82 through to late 84, in terms of HIV. But before we do that, how frequently, broadly, did the reference centre directors usually meet?
Well, as you're aware, I was invited to join in early 1980. I don't recall how frequently they met before then, but after 1980, it was every few months. It might have been 3 or 4 times a year, perhaps 3 times a year. And then there was the meeting, the annual general meeting for everybody. So there would be at least 4 meetings in most years.
And what would happen to the minutes of the meetings of the reference centre directors, whoever took them, Dr. Ritz or whoever it may have been? Were those minutes provided, as far as you're aware, to the broader population of haemophilia centre directors, or were the minutes simply for the use of the reference centre directors?
I think they were for the use of the reference centre directors.
What were the arrangements, again, as far as you can recall, from the 80s, early 90s, for the selection of the chair of the UK Hcdo?
As far as I recall, and looking at some of the minutes, I see it says the chairman was elected. Certainly when I was started as chairman, immediately prior to, there was an election. There was more than one candidate besides myself that stood, and there was an election. There was a ballot. I can't remember how we elected the chairman prior to that. It's now a more formal process. There was a formal ballot.
In the first half of the 1980s, the chairmanship was under Professor Bloom. To what extent did his voice dominate reference centre director discussions in the first half of the 80s?
I don't think his voice dominated. His views dominated. He was very keen to hear what other people's views were, and it was actually, they were very interesting meetings to attend, because I learnt of the sort of spectrum of difficulties in other places in providing haemophilia care, particularly some of the difficulties and stresses of providing a service in London.
What in general was the purpose of the attendance on those occasions where they did attend of a Department of Health representative at the reference centre director meetings?
They were an important individual to provide communication between the DOH and the reference centre directors. And as you'll have seen from the minutes, there were different people who came. They usually came for several years. Some were very helpful in providing us with a departmental view about particular situations. And I hope that they were equally helpful back at the DOH in providing our view. There were other individuals who were, if I can put it, less communicative, less helpful, and it was difficult to feel that we had a rapport with the DOH through them, but there were certainly other individuals who were very helpful and provided good rapport.
And then in terms of the bigger annual meeting, which took place involving, or to which were invited all Haemophilia Centre directors, we've had some evidence from directors at smaller centres to suggest that those annual general meetings weren't much of a forum for different perspectives or the perspectives of smaller centres to be presented. Do you have any observation on that?
They were mainly forums for giving information, for providing information to members. There were perhaps 50 or 70 people at a meeting. There was always opportunity to ask questions, to raise topics, but there was quite a full agenda to get through, and they were one-day meetings, and people had travelled sometimes quite long distances to get there, so they might have had to start at 10 o'clock rather than 9 o'clock. But they weren't meetings where there could be a detailed discussion of issues because of the large number of people in the room. And of course, the people who came, as I was suggesting earlier, came from a variety of different sized haemophilia centres, and their as a proportion, if you like, of their workload, from small associate centres that might just have 2 or 3 patients, through to other individuals who actually were looking after a lot of patients, and eventually they became designated as comprehensive care centres. So there's a big spectrum, and therefore the doctors attending had very different needs, if I can put it that way, for information.
Did you have any involvement with or knowledge of any attempts to secure sponsorship or funding, for example, for the AGM or anything else, from pharmaceutical companies?
Not at that stage. You were asking about the early mid-1980s. My recollection is there was no pharmaceutical presence at the gatherings. I think there may have been 1 or 2 meetings in 1980s, or possibly 79, because I was invited to the 1979 AGM, and I think there may have been an associated educational day with that. We would have stayed overnight. But in the 1990s and thereafter, the AGM was often accompanied by an educational day, and that involved extra expense. We would invite speakers from elsewhere, often from abroad, to get a broader perspective on haemophilia. They were costly to run, and so the relevant pharmaceutical companies were keen to have an opportunity to meet with haemophilia directors. So there was the opportunity for the pharmaceutical companies to send representatives to set up a small table in a room, a big room with tables, one for each company. The pharmaceutical representatives didn't come to the annual general meeting. That was for members of UK Hcdo and their invited guests. And their invited guests included representatives of all the departments of health, the Hemophilia Society, the various professional specialist groups, the nurses, the physiotherapists, the social workers, and representatives of blood transfusion authorities were regular invitees, and many of them sent representatives.
And to what extent, when you joined in 1980, the Reference Centre Director Group, and in the years that followed after that, did the Reference Centre Director Group regard its role as including the giving of advice or guidance or instruction to the broader members of the organisation?
That was not, I think, an original function of the Reference Centre directors. Giving advice and guidelines, perhaps call them guidelines, was something that emerged in the 1990s. And in the 1980s, 1970s, professional societies, if I can put it that way, of like-minded, like-interested physicians, like hepatologists or dermatologists, they wouldn't be issuing guidelines. As I say, that didn't really start to even be thought about to the 1990s. But with the, I suppose, the Reference Centre directors, through their activities and the information they provided at the annual general meeting, were influencing how haemophilia care was provided. If you like, it was an informal mechanism, part of developing people's knowledge, and in a sense, it was UK Hcdo's interest in promoting good haemophilia care that led to the full investigation of the Bournemouth hepatitis outbreak and the tremendous detailed epidemiology that Dr. Krask did. That was unique in the world. That nothing like that had ever been done before. But out of that became an awareness, an acute awareness of the vulnerability of certain groups of patients to hepatitis, and so that stimulated the formation of the Hepatitis Working Party, and there was no other working party like it, as far as I know, in the world, was trying to grapple with some of the issues of hepatitis, its investigation, and trying to puzzle out the best way to help the situation. And it was through their annual reports, which were made available to the general membership, that, if you like, information, latest information that was being discerned was promulgated amongst physicians. It was before the days of internet and mass communication. So this was a good way of developing good haemophilia care.
I'm going to ask you to look at a handful of documents relating to the UK Hcdo's and in particular Reference Centre Director's response to the AIDS crisis and ask for your observations. So if we start with CBLA 301619, please. So this is September 1982. This is the bigger meeting of Haemophilia Centre directors. There had been, not long before this, a few days or so before this, a meeting of reference centre directors, but I just want to pick up the picture here, if I may. If we go, please, and you were on the list of attendees, Professor. If we go, please, Seamus, to the bottom of page 9, to start with. So we can see at the bottom of the page, we get a report from Working Party Chairman, and under the heading Hepatitis, we get a report from Dr. Krask. I won't go into the detail of that, but if we go over the next page, we can see that he talks about the possibilities of a study being undertaken and the possibilities of further studies. He talks about the Hepatitis B vaccine. And then the bottom of the page, under the heading Acquired Immune Deficiency Syndrome, it says the reference centre directors had asked Dr. Krask to look into the report from the US of this syndrome, mainly in homosexuals, but including 3 haemophiliacs. And then there's this sentence: it appeared that there was a remote possibility that commercial blood products had been involved. Do you know whether you saw these minutes at the time and this characterisation of the potential causal link?
I don't. I think it reflects that. I suppose there were 3 by that stage. There were 3 cases of AIDS that had been reported in July of that year, and therefore there was the possibility that they had acquired it from blood products, from their concentrate, because they didn't apparently have other known risk factors. I didn't write the minutes clearly. It was presumably wanting me to concentrate on the word remote.
Yes.
I think it was clearly a possibility. And at that time, there was puzzlement. I can't defend the word remote. I think it'd be better to say there was a possibility that commercial products had been involved.
Okay, we'll move on then to the next reference centre director meeting chronologically, which was the 14th of February 1983. It's Hcdo 40411. Before we look at the minutes themselves, you'll just see that this is a letter dated the 9th of May, being sent by Miss Spooner, sent to all present at the meeting, in relation to a meeting held some months before on the 14th of February 1983. It seems rather a long period of time, particularly at quite a critical time, for there to be, before the minutes are being sent out. I'm not asking you to, expecting you to be able to comment on this particular set of minutes, but can you recall whether long periods of time typically elapsed before minutes were received by the directors?
I'm sorry, I can't help you. I don't recall there being a long time. They were quite full minutes. Miss Spooner was a very busy person, if I can put it that way. She was the hub of the correspondence that came in for Hemophilia centre directors and the database in Oxford. So she was very busy, very dedicated, very hardworking. But I don't recall how long it normally was before we got copies of the draft minutes.
If we go to the next page, we can see that these are headed draft. We don't have a further copy, Professor, which is why I'm showing you the draft. Minutes of the 16th meeting of Reference Centre Directors, 14th of February 1983. We can see that you were present. If we could go to page 5, please, Shomik. You'll see there under the heading The AIDS Syndrome, we see Professor Bloom recording that there's going to be a discussion at the Stockholm meeting at the World Federation of Haemophilia, reports from the US indicating that the incidence was higher than at first thought, a summary of information from Dr. Krask, approximately 10 cases of AIDS now thought to have occurred in non-haemophiliacs in the UK, London, Glasgow, Manchester. And then it talks about the draft form, a lengthy discussion regarding the form and documents which Dr. Krask has obtained, which are going to be circulated. And then if we just go down a bit, it was agreed that Dr. Krask should draw up a new form for the reporting of cases and arrange for this to be circulated to all Haemophilia Centre directors with appropriate notes, and then a suggestion of inviting an immunologist to join the hepatitis working party. So this is the middle of February 1983. I'm not going to go back over any of the material we've looked at already, in particular yesterday, about what was known by this time and what wasn't known at this time in relation to AIDS. What's being agreed here is simply the sending out of a form and inviting directors to report cases back to Dr. Krask. There's no discussion here about treatment policies, no discussions about what, if any, information to provide to patients. Do you consider that the Reference Centre Director's response at this stage was an adequate one?
It's an important and a good question, and you see by my delay in responding, I think it reflects that this, if you like, arrangement for further inquiry rather than action in terms of what might be considered to do to about the threat, I think reflects the uncertainty as to about what was happening. What was? Why were patients with haemophilia, a small number in the States, being so diagnosed, and what was the cause? General puzzlement. I think that's what this is reflecting, trying to gather up some more information to try and help think further about what the difficulty might be.
Do you, in relation to the last sentence that we looked at there. I may be able to check this from the Hepatitis Working Party minutes in due course, but do you know whether an immunologist did join the Hepatitis Working Party?
If they did, I'm sorry, I've forgotten their name. I don't think an immunologist, the minutes are with the inquiry. Whilst I appreciate on the list of attendees, it doesn't say what their specialty is, but most of the attendees, I put it this way, were well-known haemophilia treaters. So if there were individuals who weren't haemophilia treaters, then that would initiate an inquiry. For example, Dr. Trowell was an Oxford-based hepatologist, and she was certainly a member of the Working Party at one stage.
There was then a special meeting of reference centre directors on the 13th of May 1983. So, Shimit, could we have Hcdo 603_008, please? So we can see minutes of special meeting of Haemophilia Reference Centre directors, 13th of May, list of attendees, you're there, Dr. Wolford from the Department of Health is there. And if we just look at the opening lines below the list, we see Professor Bloom briefly outline the background to the meeting and its purpose, refers to recent publicity in the press about AIDS, anxiety to haemophiliacs and their medical attendants, clearly a need for Haemophilia Centre directors to discuss what should be done with regard to the surveillance and reporting of suspected cases and management of patients, and then there's a reference to one haemophiliac suspected of suffering from AIDS, which certainly we understand at this stage to be the Cardiff case, Professor. This was a special meeting. It was called for a particular purpose. What, if anything, do you recall about it?
If I could say before answering that, I noticed that Dr. Wolford from the Department of Health, you could see the top of the letter at the form again. Dr. Diane Wolford. I'm pleased to see that she was there. She was someone who took an active interest in UK Hcdo activities and was a useful contact at the Department of Health. To answer your question, I'm afraid I have no memory, unless you can jog it in some way just now, of the actual meeting itself.
Okay. Well, if we go over to the second page, we can see what was discussed from the minutes. The first page is a further discussion about Dr. Krask's reporting system, if I can characterise it in those terms. And then the second paragraph says the steps to be taken should a patient develop the features of a full-blown condition were discussed. Agreed insufficient information available from the US experience to warrant changing the type of concentrate used in any particular patient. Moreover, once the condition is fully developed, it seems to be irreversible, so there would seem to be no clinical benefit to be gained by changing to another type. So that appears to be a discussion about a very specific situation, what you do in relation to the treatment of a patient who develops full-blown AIDS. Is that a fair reading?
Yes.
And then we see the third paragraph, so it is now looking at questions of treatment and says this: with regard to general policy to be followed in the use of factor VIII concentrates, it was noted that many directors have up until now reserved a supply of NHS concentrates for children and mildly affected haemophiliacs. It was considered it would be circumspect to continue with that policy. It was agreed that there was as yet insufficient evidence to warrant restriction of the use of imported concentrates in other patients in view of the immense benefits of therapy, and it goes on to say the situation will be kept under review. So the decision that appears to emerge from these minutes is just if you're already reserving NHS concentrate for those two categories, children and mildly affected haemophiliacs, continue to do so. Is that again a fair reading of the minutes?
I think that is a fair reading, and I think that the policy that this is referring to emanates from the experience and the work of the Hepatitis Working Party, and particularly, I'm sorry to go back to well, I'm not sorry to go back, but I go back to the Bournemouth episode that a lot was learned about risks. So this policy in this paragraph was what was considered good and desirable, where possible, treatment for these groups. Yeah.
And it would appear from the minutes, assuming them to be a reasonably accurate summary, that there was no discussion of the question of what to tell patients, if anything, about risks or alternative forms of treatment. As far as you can recall, was that question addressed by the reference centre directors at any point before the December 84 Elstree meeting?
As you see by my hesitation, I'm having difficulty recalling. It's difficult to recall something if it didn't happen, if I can put it that way. I can't at the moment recall discussion at the reference centre director meetings. The Hemophilia Society had a medical advisory panel, and I think Professor Tubman said that he was a member of it, so he might be able to help you with what information was given to the Hemophilia Society. I don't know anything about their meetings at that time, or what was said by the people on their medical advisory panel to the Hemophilia Society, and through it, obviously, and through the literature that we discussed or made reference to yesterday. But as far as the reference centre were concerned, I can't at the moment recall discussion about what should be said to patients, perhaps because we were aware that the Hemophilia Society was being kept informed by its medical advisory panel, but I don't recall any discussion about, can I put it this way, going out to proactively speaking to patients about AIDS. Had we received the Council of Europe report that you showed me yesterday, then that clearly made some recommendations that at least we would have considered, and had we considered them, we might well have agreed with them. But as I indicated yesterday, I certainly never saw them, and I think if they'd been made available to Professor Bloom, he was good at sharing information, as some of the correspondence that the inquiry has about his activities in 1983, 1984. He was a good communicator with people. He shared information. He made inquiries. He led the discussions well at the meetings.
We'll have a look at the letter that was put together following this special meeting to send to Haemophilia Centre directors, because I just have a couple of questions about that I wanted to invite your perspective on. It's Hcdo 40270_004. So this is a letter of the 24th of June 1983 sent by Professor Bloom and Dr. Ritzer, and we can see from the text it refers to the special meeting, the minutes of which we've just looked at, and then it sets out recommendations. At the above-mentioned meeting on May the 13th, the following general recommendations were agreed. 1, for mildly affected patients with haemophilia A or von Willebrand's and minor lesions, treatment with DDAVP should be considered because of the increased risk of transmitting hepatitis by means of large pool concentrates in such patients. This is in any case the usual practice of many directors. And then for 2, for treatment of children and mildly affected patients or patients unexposed to imported concentrates, many directors already reserve supplies of NHS concentrates, cryoprecipitate or freeze-dried, and it would be circumspect to continue this policy. And then there are a couple of further points in relation further down the page about haemophilia B and hepatitis-reduced concentrate trials. But just looking at these two, what's described as general recommendations, the first falls short, doesn't it, of being a positive recommendation. It's inviting recipients to consider the use of DDAVP and observes it's the usual practice of many directors, but it doesn't actually go so far as to say this is what we think should be done.
Well, I think it's quite well worded, actually. DDAVP should be considered. DDAVP is contraindicated in some patients with von Willebrand disease. Can cause particular problems. I can go into those if you want. There's not all patients with von Willebrand disease respond well, hemostatically, if I can put it that way, to desmopressin. And mild haemophilia is a very broad spectrum disorder, and the response varies quite markedly between individuals. But as I mentioned yesterday or the day before, within one individual, the response is quite good. It's quite consistent. And so DDAVP should be considered, I think, is appropriate.
What about the second paragraph?
Or one could say considered first or considered prior to blood product use.
What about the second paragraph, Professor Ludlam, which simply really describes what's said to be a state of affairs, that many directors already reserve supplies of NHS concentrates, cryoprecipitate or freeze-dried for those two categories, and it would be circumspect to continue this policy. That would appear to be no more than the recommendation of the continuation of a status quo for those directors who are already doing it.
I think it would encourage people to do so, because if they weren't doing that, they would be. This policy set out in 2 was clearly desirable, and if they weren't doing that, then they would see that they were out of line.
Why was it you may not be able to answer this, but you are the only reference centre director left a question I can ask this of. Why do you think it wasn't put in stronger terms?
I think that perhaps to some extent reflects the sort of people that Professor Bloom and Dr. Ritzer were. They were keen to encourage people to, as they would see it, improve haemophilia care. And they were both very polite individuals. And I think this was a sort of turn of phrase, and it was a way of encouraging people along. In those days, there weren't protocols like there are now that make strong recommendations about what you should do. This was both Dr. Ritzer and Professor Bloom promoted haemophilia care by encouragement rather than directive. And I think this reflects the way Professor Bloom approached things.
We've seen reference in some materials and discussed with some witnesses a concept of clinical freedom, effectively the entitlement of the clinician to take their own decision as to what treatment they should prescribe for patients. Did that concept, whether couched in those terms or otherwise, feature explicitly in reference centre director discussions?
No, I don't think so. No.
Now, the next reference centre director meeting...
Just
yes.
a moment, if we just stay on that page. It's the use of the word circumspect that hits me, I have to say. From what you've just said, the politeness of Professor Bloom and Dr. Ritzer might have been better expressed had they said such a policy should be encouraged. But it would be circumspect to continue this policy is really, I'm not altogether sure what it's saying except carry on as before. Can you help? It's just a choice of words.
I agree it's a choice of words. And I think perhaps this reflects a rather more gentler way of life perhaps than there is now. And I can see that it could be worded differently. But I think the message was clear.
Thank
you. The next reference centre director meeting, Professor Ludlam, was the 19th of September 1983. And Shamit, can we have Hcdo 40413, please? We can see the date at the top of the page. We can see your attendance. We can see the chair welcoming Dr. Walford, invited to attend the meeting in view of the department's interest in AIDS. If we then go on to page 3, please. You'll see under the heading Current Situation Regarding AIDS that it is by now known that a haemophiliac patient in Bristol has died. They died in August of 1983. And so there's a discussion about tracing up donors of the and so on, and discussion about batches. There's then, if we would just continue down the page, There's then, as you'll see from the top of the second paragraph, a discussion about whether the method of supply of blood products should be changed so that it's supplied via regional transfusion centres. And if we go towards the bottom of the page, we can see about 5 lines up from the bottom, many of the reference centre directors had grave misgivings about this scheme. We go over the page. There's then, in the first main paragraph, beginning the position regarding, there's a discussion about the extent to which information is being disseminated to the Communicable Disease Surveillance Centre, because Dr. Galbraith has raised concern that he was not informed about the Bristol case. And there's a debate about that. And if we go towards the bottom of the paragraph, we can see the agreement is that reporting to CDSC should be through Dr. Krask. And then we can see that there's a, bottom of the page, there's a proposals from Dr. Krask in relation, again, to collecting data. That continues over the top of the page. And then there's a reference to the Haemophilia Society having asked Professor Bloom to update an AIDS circular, which is read through and approved. So by this time, the reference centre directors are clearly aware of the death of a patient. There is, would you agree, still no discussion about providing information to patients as clinicians? We leave aside anything that the Haemophilia Society might send out. Would you agree?
Yes.
Was it to your knowledge, the reference centre director's view that questions of what information should be given about the risks of treatment was more a matter for the Haemophilia Society than patients' clinicians?
I think it was becoming, I think, a very general knowledge that there was possibility of infection through commercial concentrates. I don't recall any discussion about whether patients should be, if you like, contacted directly. I suppose I'm looking at this sentence about Professor Bloom read through the document he had prepared for the Society, and this was approved by the reference centre directors. I assume this refers to the document or the paragraph that he had written in May 1985, earlier, 83, earlier in the year, which he had written at the request of the secretary, I think he was called, of the Haemophilia Society, David Waters, because before that, at the beginning of May, there'd been an article in the newspaper about the possibility of HIV being passed to patients in the UK through US concentrates. And so there'd been some anxiety amongst patients who had rung up the Hemophilia Society, and the Reverend Alan Tanner and David Waters are clearly receiving a lot of calls, and David Waters rang Professor Bloom and explained they were getting a lot of inquiries. Could he write something reassuring for the patients that they could send round to the patients in the Haemophilia Society? So he wrote the paragraph that I think stated the 4th of May. So I think this refers to that document. And I think there was some doubt about how the patient had been labelled as having AIDS. As you know, the Hepatitis Working Party had sent out documents, questionnaires in March '83, telling haemophilia directors about AIDS and asking for reports, to send reports in to Dr. Krask. And his letter was accompanied by an information sheet about AIDS. It's headed the AIDS 2. And this listed diseases specific for AIDS. And in the list is Candida, thrush, oral, pharyngeal, esophageal, or systemic Candida. And this was how AIDS apparently was being defined. I dwell upon this because I think this is the same document that was actually sent around US haemophilia centres in 1983, because I've seen a document from there that looks very like this. And I think it's interesting that this document suggests that individuals with oral or pharyngeal Candida should be classified as having AIDS. Now, we've not discussed at all the definition of AIDS, and originally it was called GRIDS, Gay-Related Immune Deficiency Syndrome, because of the homosexuals who were the first to exhibit the clinical symptoms. The first definition of AIDS was suggested by CDC and the MMWR, I think in the 23rd of September 1982. And that listed a long list of opportunistic infections that would lead one to make a clinical diagnosis of AIDS. And I would say this, I can provide the document if you would like, but basically making a diagnosis of AIDS was a clinical diagnosis. There were no laboratory tests at all. It didn't depend upon measuring T-cell subsets or skin reactions. It was if you had no other reason for immune deficiency, then, and you developed one of these so-called opportunistic infections, then you were designated as having AIDS. And the opportunistic infections were very variable. It depended where you lived. If you lived in Central Africa, you got the wasting syndrome, the diarrhea. If you lived in North America or the UK, you were much more likely to get a pneumocystis carinii pneumonia. But I would come to the issue of esophageal candidiasis, or esophageal candida, rather, that if you had candida in your mouth or throat, and that was actually not all that uncommon in the general population, if I can put it that way, but the moment it starts to go down your esophagus, then you suddenly change from not having AIDS to having AIDS. And that's quite a threshold to cross, as you'll appreciate.
Professor,
you have a little candida. I'm sorry?
Sorry, Professor Ludlam, the question I'd asked you was about the absence of any discussion by the reference centre directors of providing information to patients about the risks of treatment. And I'd asked you whether there was some perhaps assumption by reference centre directors that this was something that could be delegated to the Haemophilia Society rather than being the responsibility of the clinicians. So I wondered if we could just come back to that.
I don't think there was positive discussion about that approach, no.
Okay.
But could I continue with what I was saying? Because I think it is relevant if we're thinking about the minutes of this meeting. And and who should be reporting potential AIDS cases to Dr. Krask or to CDSC. And so it was, what I was trying to explain was that the diagnosis of AIDS could occur if the candida infection spread from the mouth and throat down to the esophagus or gullet. And I think Dr. Galbraith, I should say, had also written in the either BMJ or the Lancet in, I think, March or April, asking for cases of suspect AIDS to be notified to him. So we know Professor Bloom had an individual with haemophilia who had esophageal candida. He told the Haemophilia Society annual general meeting of this in the end of April '83. And you've heard about the request for the paragraph that he wrote in, I think it's dated the 4th of May. And that was clearly the trigger for Dr. Galbraith writing to the Department of Health about the safety of imported concentrates. There's been concern about the wording about no definitive case of AIDS being known in the UK at that time. Professor Bloom wrote that. And I think, and yet, 2 days later, the CDR report stated that there was a patient with AIDS in Cardiff, a 20-year-old individual with esophageal candida. And so these two documents don't fit comfortably together. I've, as you see, tried to piece this together. And the other thing that has puzzled me is why later on in the year, the minutes of meetings refer to a suspect case of AIDS in Cardiff. And the reason it's referred to as a suspect case is because in Dr. Krask's view, it was still under investigation and therefore should be called a suspect case. That's a matter of semantics. But I would move forward to the letter that appeared in the Lancet on the 10th of December 1983. I wonder if I could possibly have the document.
Professor Ludlam, I'm slightly concerned we may be going off topic. You'll have an opportunity tomorrow to add things, but I'm quite keen before we finish today to just try and finish the topic of the UK Hcdo's response to the AIDS crisis. Is the article in the Lancet in December 1983 relevant to the evidence you want to give on that issue? If not, could we perhaps come to it tomorrow?
I'm happy to come back to it tomorrow, and I'm sorry to have distracted you, but I think this is an important issue, and perhaps we could return to it.
Yes, certainly.
Yeah, thank you.
Could we then just if we can just stick with the chronology of UK Hcdo meetings, there's only one further set of minutes I want to ask you to look at for present purposes, and it's the bigger Haemophilia Centre Directors AGM in October 83. It's PRSE 304440. So you'll see the date 17th of October 1983 and the long list of attendees. Could we go to page 10, please, Shomek? Yes, so if we go to the bottom half of the page, you will see Dr. Chisholm raising an issue about cryoprecipitate and reversion to cryoprecipitate. And there's just one passage in this I want to ask your observations as a reference centre director of the time on. And that's Professor Bloom's reported response, where he says he felt that there was no need for patients to stop using the commercial concentrates because at present there was no proof that the commercial concentrates were the cause of AIDS. And then there's a discussion that follows in relation to supply issues. Do you have any insight as to why, if these minutes are accurate, Professor Bloom was stating that there was no proof that commercial concentrates were the cause of AIDS and thus no need to do anything?
There was good circumstantial evidence. But I suppose it is true to say there was no proof, but good circumstantial evidence.
Do you recall this discussion at all? One meeting in October 83. Do you have any recollection of it?
I'm sorry, I don't. I do recall I think Dr. Chisholm was actually quite keen on cryoprecipitate. The only reason I make this comment is because the meeting I organized in 1997 to discuss the question of variant CJD and the risk from UK blood products. My recollection is that Dr. Chisholm was actually very keen that we reverted to the use of cryoprecipitate, which I had some difficulty with, but that was her view. So I think she must have been. She was a good attender at meetings, and she was interested in haemophilia and knew a lot about it. And she ran a small centre. Beyond that, I'm sorry, I don't remember this particular bit of discussion meeting.
If you'll take it from me, Professor, that there were then two further reference centre director meetings in 1984. I'm not going to take time looking at them because it would be to prove a negative. There's a meeting on the 13th of December 1984. You have the minutes. There was then a meeting in September of 1984. Again, you have the minutes. There was, again, neither of those discussions feature any deliberation as to what information should be provided to patients. And then we get to the December 1984 Elstree meeting, where we see for the first time a discussion about telling patients their diagnosis and about being tested at that stage, not about risks, because that moment, as it were, has gone. And we see for the first time the production of guidelines in the form of the AIDS advisory document. That's December 84 in circumstances where the MMWR that first reported AIDS in haemophiliacs was 2.5 years previously. As a reference centre director, do you consider that that was an adequate response by the group of reference centre directors, or far too late?
I think the policy, if I can answer this in two parts, the policy of the treatment policy, the continued use of US concentrates and how they were used, is in keeping with the policy that there was in the United States, the National Hemophilia Foundation, that had had extensive discussions with people like Bruce Evett at the CDC. And their policy was to continue to use concentrates. And looking from where I sat, it's and also there was the view, the NHF about children, if possible, being treated with cryoprecipitate. But if it was a policy in the country where there was a lot of AIDS in the general population, then for continued use of concentrate, then that was possibly a reasonable policy for other countries to adopt. Now, you're not asking me to, I think, review or are you whether concentrate, the importation of concentrate should have been reviewed differently or viewed differently rather than reviewed differently.
I'm not asking you that question, Professor. No. It's the question of whether the reference centre directors should and could have done more earlier. May not have, a ban on imported concentrates was not in the reference centre director's gift, but reference centre directors failed to address at all in this 2.5-year period, as far as we can see from the minutes, any question of giving the provision of advice or warnings about risks of treatment to patients. And the only recommendation in relation to treatment is what we saw in that letter of the 24th of June 1983. Do you think that was good enough?
As I was indicating yesterday, my memory of who knew what, when, over this time period is fading. But my recollection is that patients were actually pretty well informed through the general press and television about risks and American imported blood products. And I'm interested, as I was mentioning right at the beginning today, reading last night the statements from two of my registrars who are a bit younger than me and have rather better memories, that patients were, one of them says, well informed and happy to talk about it. And it was a topic of general or not uncommon conversation when they came up for clinics or with bleeds. So, and many patients were members of the Hemophilia Society, and if they weren't, as I've described earlier, Hemophilia Society literature was made available to patients. So I think there was the general feeling, and I think probably accurate, that the majority of patients were aware of the possibility. How high you put that possibility, I agree, could be considered. But there were clearly people who were coming up to the clinic and talking about it in Edinburgh. And the Hemophilia Society were receiving phone calls after newspaper articles. And as the records show, that there were quite a lot of newspaper articles over this period related to this topic. So I think there was the reasonable view that patients were aware of the risk. The question you've put to me is, should the reference centre directors have been proactively going out and asking haemophilia directors to tell patients? And as I mentioned earlier, had we received the Council of Europe a directive, maybe we would have sent out such advice. So that's the background, and that I think is why the reference centre directors didn't issue specific instructions or guidance.
Okay, thank you. So I note the time, and I'm going to move to a completely different topic next. So
Yes, well, we will take a break in that case. Thank you, Professor. We'll take a break till tomorrow morning at 10 o'clock and look forward to seeing you then.
Thank you.
10 o'clock tomorrow morning.